moment, I am going to yield the floor to Dr. Samuel Ahn. It's been my pleasure to work with Dr. Ahn for the past couple of years as he continues his epilepsy fellowship. I first met him as a resident and have worked with him in clinics. He's an outstanding physician and, in my opinion, an emerging star. And I really look forward to having him address you now. So Sam, you can take it away.
Thank you, Dr. Sankar, for that very nice introduction. I appreciate it. I hope I can live up to your expectations, but I'm happy to share my screen now. All right, and I hope everyone can see my screen. I'll scoot back just a little bit. All right. So everyone can hear me? Okay. All right, sorry about that technical difficulty. Hope everyone can hear me again. So my name is Sam Ahn. I'm an epilepsy fellow at UCLA, and I'm happy to have the opportunity to speak with everybody here and just talk a little bit about, a big question that I think comes across any patient or family member's mind when, someone is affected with seizures is, what is actually the cause of the seizures? What's causing the epilepsy? It's a big question, and a question that I, as a neurologist and an epileptologist, ask myself every day with every single patient. So, it's something that I ponder, on a regular basis. Now, the scope of this talk, I want to kind of provide a framework for understanding how a neurologist and an epileptologist approaches understanding epilepsy or classifying a patient's epilepsy type. And this is important because it helps us to understand, once we are able to glean the cause of the epilepsy, what may be the most appropriate therapy or the treatment, and even more questions that linger on, particularly about, what are the chances of being seizure-free in the future or being cured of the epilepsy. So I want to emphasize that being able to classify the epilepsy type and understanding the cause of epilepsy is paramount in how we decide to approach therapies for the seizures. Then I'll go over a broad overview of the various causes of epilepsy, and we'll get into it. So the first diagram I have shown here is one from the International League Against Epilepsy, which is a consortium of many different physicians, providers, anybody who basically has devoted, their time to understanding seizure disorders and working against epilepsy. But the ILAE releases, statements about epilepsy, kind of combining more recent research and discoveries that we've made to update their findings and how we can understand the epilepsy. So this is one diagram that was created in 2017. And I admit it's a little bit complicated diagram. It's not my favorite to show, but I think it helps to provide a lot of information about understanding epilepsy on one slide. So like I was mentioning, these classification schemes are meant to compartmentalize and simplify our framework for providing the most appropriate care. Typically it starts with when a patient presents with a seizure for the first time, what type of seizure is it? And I don't want to get into too much details about describing the seizure type. I'm sure many of you have understood this sort of dialogue before, but if we can characterize a patient's seizure type as a focal or generalized seizure, perhaps they have a combination, or we're just not able to completely gather all of that information. But with that, we're able to categorize epilepsy type. And with the epilepsy type, we consider other comorbid conditions such as developmental delay, intellectual disability, autism spectrum disorder, depression, bipolar disorder. And these comorbidities invariably affect the epilepsy itself. And when we think about the underlying cause or the etiology, which is what really I want to focus on today, there may be multiple different causes for any epilepsy type. Yeah, it's quite complex, but I hope I can clarify some of this here. So the ILAE also has described at least 30 different epilepsy syndromes. And a syndrome is essentially, aside from the seizures or the epilepsy, a cluster of features in a patient incorporating the seizure types, the EEG findings, perhaps neuroimaging or MRI findings that tend to occur together. And as you can see here, these epilepsy syndromes are often categorized or stratified based on the age of onset or the age at which patients present. These age-dependent features, such as the onset, age of admission, potential seizure triggers, and even prognosis, all are incorporated into describing these epilepsy syndromes. I think classifying these syndromes provide prognostic, therapeutic, and genetic value. Once we are able to understand how certain epilepsy syndromes kind of operate or behave, and once we are able to meet with many different patients with a similar condition, we start to understand patterns and even patterns to treatment and response to treatment. So an epilepsy syndrome, particularly in the pediatric neurology setting, is paramount, and we always think about this. I want to emphasize that describing an epilepsy syndrome is not exactly the same as describing a cause for epilepsy or the underlying etiology. Take, for example, West syndrome. West syndrome is an epileptic syndrome in infancy characterized by epileptic spasms, a very chaotic EEG background called hypsarrhythmia, as well as intellectual disability or developmental delay. And there can be many causes for West syndrome. One of the most common genetic causes is tuberous sclerosis complex, or TSC, which you'll hear more about from Dr. Rajaraman, as well as trisomy 21 or Down syndrome. These are quite common genetic causes for West syndrome or epileptic spasms. But overall, the most common underlying cause of West syndrome is birth injury, and neonatal birth injury in particular. So while there can be a similar presentation in a patient with epileptic spasms, the underlying cause may be different, birth injury versus a genetic cause versus others. So it's just one example of how there's not a one-to-one correlation with an epilepsy syndrome and the underlying cause. So getting a little bit more into the underlying causes or etiologies, sometimes we say. So, there are many, but focus mainly on a few. There are genetic, structural, metabolic, immune, or infectious causes. So, a genetic epilepsy is described as, an epilepsy or seizure disorder that is associated with a known or presumed genetic defect. A genetic epilepsy doesn't always mean that this epilepsy has been passed down from generation to generation. Well, that certainly is one of the causes of genetic epilepsies. We typically characterize that as an inherited genetic epilepsy, meaning that a patient or a child has inherited one or both copies of an abnormal genetic product from one of their parents. So with inherited cases of genetic epilepsy, there may be a preceding family history of epilepsy. And it helps even when we see a patient with epilepsy, if there's a strong family history, we may even be able to make a presumed diagnosis prior to getting any other studies. But there are also acquired causes of genetic epilepsies. And this occurs when a patient or a child has acquired a defective gene product. And this can be a result of cells dividing as a baby or is growing within the mother. And, this genetic abnormality, while it's not necessarily passed down from a parent, is often caused a de novo event or coming out of new. And this means that the genetic changes happen when the cells are dividing and forming in the body. There's also mosaic conditions, which mean that the genetic mutation is present in some, but not all of the cells within an individual's body. Now, polygenic genetic epilepsies refers to types of epilepsies that are result of changes in many different genes that together as a sum add up and lower that threshold for any individual to have seizures. And this often is the case with many of the genetic generalized epilepsies that occur in childhood. For example, absence epilepsy or juvenile myoclonic epilepsy, where despite working to do a genetic workup, we haven't quite identified a single cause. But over time, we're starting to understand more and more that there may be multiple different genes that interact with each other that then adds up to create a seizure disorder in any particular person. Now, the evaluation for genetic epilepsy entails a genetic workup, aside from the standard EEG and any other neuroimaging studies that we may acquire. A genetic study in the infantile or neonatal period often starts with a simple evaluation of the chromosomes or chromosomal microarray to evaluate for any large deletions or duplications in the genetic makeup. Now, more recently, and some of you may be familiar with epilepsy genetic panels, but there are now companies that offer genetic panels which have any number of gene mutations that are associated with epilepsy, and these are tested in a patient. This could be either a blood or saliva sample that's sent. One of our usual testing sites is through Invitae, and the panel here shows a number of genes, 290 genes and counting, that are offered within the Invitae epilepsy gene panel. And we offer this panel typically in patients who have medically refractory epilepsy, in whom we have a reasonable suspicion has a genetic underlying cause for the epilepsy. Also, if there's any concurrent developmental delay or intellectual disability with an epilepsy, sending the MBT genetic panel may be of use. I also want to highlight one of the programs through MVT called Behind the Seizure, in which any epilepsy gene panel from MVT is offered for a patient with epilepsy under the age of 8 years old. So I encourage, any parents or patients under the age of 8 who have medically refractory epilepsy or any other comorbid conditions to consider obtaining or ask your provider about, genetic studies. I think it's important to look at the person as a whole when considering genetic syndromes. This can often have overlap with many metabolic abnormalities. Even special diets can be helpful. Ultimately, I think understanding more about the genetic changes in rare epilepsies can help us gather more information and ultimately see in the future specific targeted therapies. And currently, a lot of these studies are in the research phase, but we're continuing to try and grow this research. Also, lastly, about genetic epilepsies, if anyone receives a genetic study, they may have encountered a result describing a variant of uncertain significance, or a VUS. And these VUSs are usually changes within the genetic makeup that are not always consistently present within the epilepsy population, nor in a normal population without epilepsy. Now, this is an ever-growing list of identified genes with functions and relationships with each other. And when we encounter a variant of uncertain significance, we look a little bit closer into what exactly was found and what's different. While there may not be a clear answer with the initial result of a VUS, we oftentimes readdress that VUS later on down the line when we are able to gather more genetic results and studies from patients all over the world, and we may be able to see patterns emerge out of these variants of uncertain significance. So even if one result is a variant or a VUS at one point, it may not be even a year, 6 months down the line. So, I think it's important to remember these variants and not ignore them as something that, is definitely not causative. Regarding structural causes for epilepsy, there are many different causes based on age. I think one of the main features of this is that there is some underlying structural abnormality or a disturbance that is responsible for generating the seizures themselves. And there are, a plethora of different structural causes, that can lead to seizures. Anything that causes some structural or any sort of architectural distortion within the brain may result in seizures. Now, I've highlighted here some of the most common causes based on age groups. In newborns, one of the most common causes of epilepsy is birth injury, or a medical term that we sometimes use is hypoxic ischemic encephalopathy, or HIE. And this results oftentimes from a baby not receiving adequate oxygen at the time of birth. And this sometimes can lead to injury that later on results in seizures. The seizures themselves can be acute symptomatic or just occur right at the time of the injury, or they may persist even after the injury has recovered, and the resultant scar of the injury then serves as the cause. In infants and children, one of the more common causes, when they initially present in that age period, is a focal cortical dysplasia. which is a malformation of cortical development, either when the cells of the brain are dividing, organizing, or moving, throughout the brain, there can be some problem with that process that then leads to an abnormal collection of cells that create a focus for seizures. And I have an example here showing a focal cortical dysplasia. There's a particularly bright spot coming from one part of the brain, and this represents the right hemisphere. So neuroimaging is important in describing any sort of structural causes for the epilepsy. And a cortical dysplasia may be one of the most common causes in a patient presenting with a structural etiology for this. In adults, one of the most common causes for epilepsy in adults, period, is mesial temporal sclerosis, or scarring within the mesial temporal lobe. This can involve the hippocampus as well. This is worldwide the most common focal epilepsy type, particularly among adults. And mesial temporal sclerosis may be something that was there since birth, or this may also be an acquired process, and still a lot of research is going on to understand the underlying pathogenesis, or the process for how temporal sclerosis develops in adults. Importantly, brain trauma or head trauma is a cause for epilepsy, and a structural cause for epilepsy. Aside from the initial injury itself, this may result in bleeding within the brain that then, similarly to a stroke, can cause scarring that then is an irritable focus for seizures. In elderly patients and seniors, the most common cause of epilepsy beginning in the senior elderly period is strokes. And, stroke affects individuals worldwide from all different backgrounds and with different risk factors. Another important cause of seizure disorders in seniors is neurodegenerative diseases, or one of the more common causes, Alzheimer's disease or dementia. The progressive loss or atrophy of tissue within the brain also can distort that structure, which then leads to seizures. So as you can see, when we talk about structural causes for epilepsy, there really are many different causes, and it's important, I think, to come back to the patient again first, and consider what is more common for this age group. What should I really be thinking about? And this is something that I consider all the time. Across all age groups, I would be remiss not to mention brain tumors as a potential cause for epilepsy or seizure disorders. And while the diagnostic workup and the treatment for brain tumors, is drastically different, and involves, a multidisciplinary team to care for a patient with a brain tumor. Epilepsy may be one component, and we understand that tumors can be a cause for that. Ultimately, I think I want to emphasize that, with neuroimaging, I personally am not a radiologist, so I rely heavily on my colleagues in neuroradiology, and I'm really proud to say that we have excellent neuroradiologists within UCLA that are able to provide this really detailed and nuanced information. Just in terms of other structural causes, there is quite a list. This is not exhaustive by any means, but really this is meant to show you that there are a lot of different structural causes. Just one change in the structure can't explain everything for all patients. Now, in terms of metabolic causes for epilepsy, The idea for metabolic causes is that, the body contains many enzymes that are responsible for breaking down various parts of the food that we eat to nourish our bodies. And, this can include proteins, carbohydrates, sugars, fats. These enzymes are, paramount in keeping everything within a strict homeostasis or within a nice balance. And if there's any sort of underactivity or blockage or even overactivity of some of these enzymes, this can lead to problems metabolizing and breaking down these products, which can then lead to a toxic buildup or accumulation of these byproducts, which then result in, injury to various organs, including the brain. There are over 750 types of metabolic disorders that have been described. This table here, again, is kind of considering the various metabolic syndromes based on age, and this is really focused on kind of the childhood onset metabolic syndromes, because this is often the times in childhood period where metabolic syndromes emerge. Importantly, a lot of these syndromes also have a genetic cause too. So, some of these metabolic syndromes are due to an underlying genetic mutation. So again, while I talk about metabolic causes and genetic causes, oftentimes these overlap together. Just to highlight a couple of the metabolic disorders, when I talk about, understanding a cause of epilepsy and this informing our treatment, very specific targeted therapies for certain syndromes or causes for epilepsy may actually treat or cure an epilepsy. For example, their glucose transporter 1 deficiency or GLUT1 deficiency, is a mutation in which basically the brain is not able to utilize glucose or sugars in the same way as the rest of the body. But one of the most important treatments for a GLUT1 transporter deficiency is a ketogenic diet rather than anti-seizure medications. So again, understanding the cause for the epilepsy may inform the treatment. Now, autoimmune epilepsies, I think are gathering a lot more recognition and understanding, especially as our technologies and the research around autoimmune epilepsies has grown. And, even within my 6 years as a neurologist, I've seen the emergence of new autoimmune diseases, completely new diagnoses that have emerged. And, it's exciting to see these growths and these changes and our understanding improve of these processes. But ultimately, an autoimmune epilepsy is characterized by a seizure disorder and a constellation of other symptoms that may include neuropsychiatric disturbances, ultimately is a consequence of one's immune system working against themselves. And this is a consequence of the body's immune functioning, creating antibodies, which usually combat infections or foreign kind of invaders into our bodies. These antibodies are developed within our bodies that then erroneously target our brain or other parts of our body. This then causes inflammation and damage to various organs, including the brain, that then results in seizures. Now, some of this characteristics, like I mentioned, these are usually characterized by focal seizures. It can present in any age period, but the diagnostic studies in particularly that are important are neuroimaging studies, lumbar puncture or a spinal tap, in order to evaluate the cerebral spinal fluid. And then we can see if there's any signs of inflammation within the brain and spinal cord. And even further, try and identify some of these antibodies that are circulating within a patient's body with autoimmune epilepsy. The treatment for autoimmune epilepsy, aside from the anti-seizure medications, if we are able to identify a specific antibody, or we have a high enough suspicion that a seizure disorder is a consequence of an autoimmune condition, an autoimmune therapy is really one of the mainstays of treatment, and that includes things that help to dampen or to suppress the immune system so that the immune system is not developing these abnormal or autoantibodies. The immune therapy can include, one of the most common immune therapies is steroids. As the therapy is stepped up, it may include things like intravenous immunoglobulin or IVIG, plasmapheresis, or even other therapies that kind of fall into the category of rheumatology or the inflammation kind of joint specialists and oncology or cancer doctors. So, these therapies sometimes for autoimmune conditions have a lot of overlap with hematologic and rheumatologic conditions. So oftentimes we work in close conjunction with our colleagues in hematology and rheumatology to help these patients. I think, so I didn't have a chance to talk much about the infectious etiologies. I might have forgotten the slide here, but the infectious etiologies, or the infections leading to seizure disorders, may be the most common cause of epilepsy worldwide. A number of different infections may result in a seizure disorder. In the developing world, one parasitic infection called Tinea solium, which results in an infection called neurocysticercosis, is the most common cause of epilepsy in developing countries. So we recognize also that infections may be a very important cause of epilepsy, both here and worldwide. And being able to seek the appropriate medical care and the attention to evaluate and undergo a workup for these infectious etiologies is quite important. Still there are, despite our efforts, unknown causes for epilepsy. And, this may be a consequence even of the resources that are available for a patient or a provider. For example, while we may presume that a patient has a genetic cause for the epilepsy or a structural cause for the epilepsy, I may not be able to exactly categorize it as that unless you're able to confirm with the proper or appropriate genetic workup or neurodiagnostic imaging studies. However, this may not be possible in certain resource limited settings. So it's also important to understand that understanding the cause for epilepsy is often a working diagnosis. Something that I consider every time that I see a patient come into the clinic, or when I see them in the hospital, what is causing their epilepsy? If I don't have an answer yet, we're still going to work towards it while we're working towards treating your seizures. So ultimately, we want to really concentrate our efforts to prevent epilepsy worldwide. And, while I am working, tirelessly to see patients already affected with epilepsy and seizure disorders, and our, ensuing talks are going to be concentrated around those patients already with epilepsy, I want to show this slide to demonstrate that there are still very preventable causes for epilepsy. The World Health Organization estimates that approximately 25% of cases worldwide are preventable. And these can even be simple things like preventing head injury, providing adequate perinatal care to prevent that birth injury. In adults and elderly patients, stroke risk factor reduction, cardiovascular risk factor reduction. These are important factors in even not only preventing strokes, but also epilepsy. Like I had mentioned, infectious causes worldwide may be one of the most common causes for epilepsy. So eliminating parasites in endemic areas is also an effort in worldwide of many providers dedicated to overcoming epilepsy. So while I continue to work with individuals and families affected, as an advocate, I hope to continue to raise awareness about this disease and to help prevent it. These are some resources that are readily available for anyone who's interested in learning more about epilepsy. I admit I was looking at some of these resources myself because it helps to provide a very clear and concise understanding about epilepsy. And while it's not exhaustive or maybe not as detail oriented or not with the most up-to-date research, I think it provides a good general overview and may help you find the resource that you're looking for. So with that, I thank everybody who has joined today. I'm happy to answer any questions. Thank you very much.
We have a few minutes for anyone to ask a question, either using your microphone or you could type in the chat box, depending on how that is set up. Perhaps, Brad, you can clarify that for the audience.
And please feel free to reach out to me anytime. I'm happy to answer questions, and I'm here for you.
Very nice job, Sam. I so far didn't see anything, but there could be questions coming through downstream because it's still early in the morning.